Many of my flights were on sweltering summer nights, the humidity a suffocating blanket. The initial thrill of donning the flight suit quickly faded. That night, we were dispatched to a hospital to retrieve a patient with severe chest pain. A suspected heart attack, likely a coronary occlusion, treated with thrombolytic therapy. The patient hadn't responded as hoped and needed rapid transport to the cath lab. No problem, a straightforward mission for our team. While these patients could become unstable, suffer cardiac arrest, or develop acute heart failure, the sending hospitals often did a remarkable job stabilizing them, administering appropriate therapies and preparing them for transport. We were essentially highly trained couriers. One of the dispatcher's first questions was about the patient's weight. The aircraft's stretcher had limitations. No problem, the nurse assured us. He's 305 at most. We landed, grabbed our gear, and rushed into the ED. As we entered the resuscitation bay, it was clear the patient was far heavier than 300 pounds. I estimated 400, and the paramedic agreed. But the nurse, the doctor, and the family insisted, "He's only 305, trust us." What were our options? Refuse transport? Leaving him there would be a death sentence. Just then, he announced his intentions and went into cardiac arrest. A malignant arrhythmia, ventricular fibrillation, had seized his heart, a chaotic fluttering like a bag of worms. Vital organs were deprived of oxygen. The required intervention was electricity. The ED physician sprang into action, applying the paddles and delivering a 360-joule shock. The patient's heart returned to a normal sinus rhythm, restoring perfusion. But the battle wasn't over. His IV blew, and the ED physician also dislodged the other during the defibrillation. Now we had a problem. While certain drugs could be administered through the breathing tube, an IV was critical. As we began the hunt for an IV site on this 300-pound patient, it became clear we were operating in the dark. We divided the extremities. The ED doctor assessed the neck, the nurse prepared for a central line, and I searched his swollen feet. A central line after thrombolytic therapy was risky, but I managed to thread a small IV catheter into a tiny vessel on his foot. It wasn't ideal, but it would suffice for transport. My partner started a second IV, and as we maneuvered the stretcher into place, the problems began. The patient was awkwardly positioned half in, half out of the aircraft door. The stretcher was partially locked but not in the correct position. Removing him risked injury to us all. Given the distance to the hospital, ground transport would delay critical intervention, likely resulting in adverse outcomes. The pilot, a hulking figure, applied brute force with his heel to the corner of the stretcher. An onlooker stared in disbelief as he seemed to be striking our patient. With a grimace and a bead of sweat, the pilot managed to lock the stretcher into place. We could now transport him safely. The patient experienced several bouts of arrhythmias en route, his heart clearly struggling. Fortunately, he responded to our interventions and returned to sinus rhythm as the wheels kissed the rooftop landing pad. We secured the elevator down to the cath lab where the team was waiting. The patient had a successful cath procedure with several stents placed, including one in the left anterior descending LAD artery. Often referred to as the widowmaker, the LAD is a notorious artery, its blockage frequently leading to sudden cardiac death. The patient had narrowly avoided a fate that countless others had succumbed to. It wasn't his day to die. He spent a few days in the ICU and recovered. As for the 305, I have no idea where he is today, but I hope he's a bit lighter. With the advent of intraosseous needles, a simple battery-powered drill transformed vascular access. In a mere 10 to 15 seconds, fluids and medications could be coursing through the patient's bone marrow. It was a medical marvel, a lifeline in time-sensitive emergencies. Video sharps@youtube.com watch. Vismavzerd.